Good morning, ladies and gentlemen. Bonjour, mesdames et messieurs. Welcome to Before the Bell, live en direct from the National Arts Centre here in Ottawa. We're very pleased that you've all chosen to join us today. Merci d'avoir choisi d'être parmi nous ce matin pour cet événement. My name is Catherine Clark. I'm one of your co-hosts this morning, along with my colleague Susan Delacourt, who's over on our other stage here. And Susan et moi, nous sommes vraiment ravis de vous accueillir ce matin. It's been a really, really dull few days in politics in Canada, here in Ottawa. And so Susan and I thought that we should perhaps have an opportunity to talk about an issue that has stood the test of times because, of course, the times they are changing. But healthcare is an issue that really Canadians have been talking about for years and years and years. And we thought this was a good opportunity for us to have a little bit of a health checkup this morning. Not surprisingly, Canadians still rank healthcare as one of their top issues, areas of concern. There was a recent Ipsos poll which revealed that 35% of Canadians, it topped the poll at 35% of Canadians, are in fact still worried about access to primary care. And so we're going to talk this morning a little bit about what's happening in the country, what are the hurdles, what are the opportunities as well. And for those of you who've had a chance to attend Before the Bell event before, and since this is only our second event, I'm going to say that might not be too many of you. I'm going to briefly explain the format of how these shows work. We have candid conversations with people who are helping to shape the policy and make the decisions about major Canadian issues. We have 3 distinct segments. After I stop talking, I'll hand things over to Susan Delacourt, who is going to get the pulse, which I think we can all agree is a very apt title for your segment today, Susan, given that we're talking about healthcare. Thank God we all have a pulse this morning. And Susan is going to be talking with her guests about the policy issues that are affecting Parliament Hill, that are affecting Canadians, that are in fact affecting Canada's place in the world. And then I will be speaking following Susan's segment, and my segment is called The Policy. And that allows me to have a bit more of an in-depth conversation with my guests about the issues that were raised in Susan's segment. And then we go to the people. That's you here in our live audience, but it's also our audience at home, and we have a really significant online audience for these events as well. And this is where I'm going to ask you to take out your mobile devices and tablets and go into your web browsers and type in www.slido.com. It's a digital mechanism that we will be using to involve audience today in the discussion. It allows you saw a little bit about it in the video. It allows you to ask questions. It allows you to like the questions of other people. And it allows you to really be engaged in this conversation today. Susan will have some polling questions as well, which you can answer through slido.com. Our hashtag, as you can see, is B2B Health. Alors, nous sommes sur le point de commencer ce matin, mais permettez-moi d'abord de mentionner nos sponsors pour cet événement. B2B is made possible with the support of the Canadian Nurses Association, Alzheimer's Society of Canada, Innovative Medicines Canada, Canadian Ophthalmology Association, the National Arts Centre, and Skyfly Productions. So thank you very much to our sponsors. And with that, it's now my opportunity to turn things over to Susan Delacourt, who is going to get the pulse.
I was waiting for the music to die down. It's all for effect. Thank you, Catherine. Lovely to see you. And as she said, it's been a riotous few days here, so I appreciate everybody coming out. Maybe your lives are not as affected as ours. I personally wouldn't mind writing in a draft for Catherine for Conservative leader. They seem to be looking for one. But we are talking today about health, and as Catherine said, we would like you to pull out your devices. You don't have to furtively check your iPads or phones. We do want you to take part in this. What this segment here is a lively conversation on some questions that we're going to talk to you about, and then we will ask these guys to have some words about it, and then we'll come back to you and see what the result is. So, I should introduce the panel. Pardon me. With me today are Bill Tholl, who calls himself a recovering CEO for a number of healthcare organizations, Canadian Medical Association, Healthcare Canada. Dr. Geneviève Moineau, and I'm going to have to read, the President and CEO of the Association of Faculties of Medicine Canada. And Peter Cleary, who's a senior consultant with Santis Canada. So they're going to field some questions, so are you. And our first one is a really broad, open-ended question. Is health an important priority for this government? Bill, you have some thoughts on this?
Well, thank you for the invitation to be here, Susan. Thanks for the question. I guess my first crack at this would be there were 364 campaign commitments in the last federal election, and 4 of them have been identified as specifically pertaining to health and healthcare. We're halfway through the mandate. Government's done a lot, starting with restoring health benefits for refugees and immigrants. We'll maybe come back to this. There's a tick in the health accord box. But as Catherine's already mentioned, Canadians continue to be worried about health and healthcare, particularly as it relates to care and support for our loved ones, our senior loved ones, particularly those with disabilities and frailty and so forth. So, and twice as many Canadians are worried about healthcare, for example, as are worried about terrorism. So, as much as that's been done by the government so far, and it's nice to see a federal government that's got an activist agenda again with respect to healthcare. It's been a long time since we've had that. So as much as they've been doing, there's a lot more that needs to be done.
Geneviève, do you have thoughts on this?
Thank you. I agree that there continues to be much to be done. However, I do believe that this government has tackled some very important issues for Canadians, including the medical assistance in dying, the opioid crisis, and others are still in the works. And so I do believe this is a good start. There is much more work to be done, and we all have to take our part in supporting the government in its work.
Peter?
I like open-ended questions because I can say yes, but.
Okay.
So when I worked in government, I always hated really quiet days in government because health was always an issue when something else wasn't happening in government. Health is always important to people, and people are quiet when it works well. And a quiet day in government was always worrisome when you're an issues guy in health because you just know something's going to come up, something's going to impact you. And even though the government does care about it, I think you referenced a couple really important signature things that have been happening, it really ebbs and flows when it's actually in the media and in the minds of Canadians. And it usually only happens when something is going wrong, but when it's working well, it's quite quiet.
Have you seen a change with the new minister? Like, has the priority moved up or down with the change of minister? Because I'm not sure Canadians know. There have been very few shuffles, but Bill, have you seen a change?
I think the big factor in terms of looking at the shift in ministers, I think everybody felt that Minister Philpott did a pretty good job. I call her a minister for health, not just a minister of health, and she understood it. As a physician, she got it.
Yeah.
I think with the transfer of the First Nations Inuit Health Branch from Health Canada to a separate ministry, which again has been called for some time by the Indigenous leaders, I think that's a big game changer for Health Canada, and the role of the new Minister of Health is going to have to be redefined, hopefully to make room for other issues.
Yeah.
And Jenny has already mentioned the opioid crisis. It's not done,
yeah.
Right? Marijuana, it's not done. So I think we're all looking forward to working with Minister Pettibone-Taylor to pick up where Minister Philpott left off.
You guys have thoughts on that?
Yeah. I think it is clear that those dossiers that have been started continue. I think that with Minister Pettibone-Taylor at the helm, there will now be a focus on mental health and addictions, as there should be. I think where we are all waiting with bated breath to hear the commitments in the federal budget for 2018 is on health research. Yeah. We know that research is one of the best ways to ensure the health of a population. Without the support for the research in Canada, Canada will fall behind not only in the health of Canadians, but also in our economy.
Peter, just...
I think Minister Petitpas-Taylor has an easier job in certain respect that three of the $4 billion of her department is now in somebody else's department. The focus that you can put on a lot of these things that have been mentioned already is allows you to actually focus on those a little bit more. But the one thing that I think is going to really crop up if we're talking about the ebb and the flow, I think pharmacare is something that's going to start taking up a lot of the time of the government. We have an MP here sits on the committee. We're anticipating a report on that. We've had moves from Ontario, and it's just a logical big policy that the new federal minister will have to take on.
Okay, we're going to go to the next question. Has the government put an appropriate public health lens on the legalization of cannabis? Again, cannabis is such a huge issue. We often don't think of it as simply a health issue. It's a law issue. It's a recreational issue. Peter, do you have some thoughts on this?
Sure. I think one of the whole reasons the government decided to make a decision on it was for public health reasons. That doesn't mean, though, that there doesn't need to be key investments in actual public health campaigns. I don't think anybody would debate that cannabis isn't. It's not like anybody's out there saying cannabis is a good product for you to have. I mean, nor is alcohol. But it's a different world that we're operating in, because at the same time you don't want to stigmatize a group that actually need it for medicinal reasons. So it's incredibly complex. The whole reason is for public health reasons, I think. But there also, and I know the government's already committed to doing it, but there also needs to be some campaigns to back that up on public health.
Geneviève?
I would agree with Peter. This is an important topic. Physicians are very concerned about the rollout, because there's clear evidence that use of cannabis has a significant effect on the developing brain. So 13 to 24-year-olds who are often the users will potentially have detrimental effects, and this affects their academic performance, and also can lead to early onset psychosis, and this has been really well proven. So what we need to do is we need to really enhance the campaign to inform the public on these risks. There's been some great work done by some provinces, particularly Nova Scotia, to actually start this campaign, and I think that all provinces need to ensure that they are properly informing their populations prior to the onset of legalization.
Thanks. Bill, do you think...
Just two additional points. Again, I echo that it's an important issue. It's a public health issue. It should be looked at through the lens of a public health harm reduction strategy rather than through other lenses. Two additional points, though. One is it's a drug, right? And do we know everything that we need to know about the administration of this drug, its counterindications, and so forth? And I think it's going to really require strong post-market surveillance once we have marijuana legislation in place, number one. And number two, where do we allow the most frequent way of using marijuana is inhaling it? What does it mean in terms of everything from allowing smoking in rental accommodations through to including in hospitals where medicinal use of marijuana is going to be used? So there are some issues there in terms of its use.
Yeah, do you think the public is seeing it through a public health lens? Or is it?
Well, it should. And I think, the other area that we really have very little information and control of is the use of marijuana in schools, the use of marijuana or cannabis by individuals who then will get into a car and drive. And we know that there are significant effects there, and the public in general does not realize that.
And thanks for saving Bill and I there. But I think July 1st, it's a date that is in people's mind. Well, maybe not July 1st, whenever it is in July 2018, it is in people's minds. But that really is still just the beginning. When you look at the complexities of distribution with recreational, then there's still going to be some complexities as the medical system evolves, especially how people will maintain having priority access in the medicinal system. This conversation is really just starting.
Okay, let's see what the audience says. And again, I'm going to need a volunteer to read out the sign because I am not hooked in on my... What's that? 48 yes. Wow. Again, this is a very seriously divided audience. Interesting. Yeah. All right, our third question is, are we doing enough for Indigenous health? And often this seems like a question we're asking ourselves more and more, I think rightly, on Parliament Hill. Geneviève, what do you think?
I would say not yet.
Yeah.
I would say the government has clearly indicated its commitment. I think the recent changes in the creation of a Ministry of Indigenous Services led by Minister Philpott, who obviously is a very effective minister, are important steps. And her focus on the social determinants of health as a first step are crucial. And so the ability of our Indigenous populations on reserve to have clean water, to have appropriate housing, those are the most important initial steps in moving towards equity in health and health services. And so I'm encouraged by those first steps. Much more has to be done, but I believe she actually is the woman to get the job done.
There was an interesting moment last week, meeting with the Métis leader, Chartrand, said that he thinks that actually Indigenous health is being improved by the fact that two women, it's sort of a collision of the Me Too movement and the division of Indigenous affairs has actually may change things for the better. Would you agree with that?
Yeah, and you know what, I think...
Basically, you're surrounded.
But I think if you had somebody from the government here and you asked them that question, I think, and I would hope they would probably say no, only because the amount that the government's doing in such a condensed period of time is nothing short of incredible in collaboration with partners across Canada. But is it going to solve reconciliation in the next 2 years? No. And I think the answer needs to be no, only to keep pressure on the government and everybody else involved to get this right.
That's a good... I foresee polarization on this one too. Bill, what do you think?
Well, back to the original question. I don't think it's possible to do enough to address Indigenous health and Indigenous health inequalities. The numbers are staggering in terms of infant mortality rate differentials, life expectancy differentials, and suicide differentials. So I don't think it's, point number one, I don't think it's possible to do enough. Two, I don't think governments can do it on their own. It's going to take a full court press, right from the regional health authorities that I used to represent and the Doctors of Canada. It's going to take a full court press. And third, it's going to take a complete change in the approach. It's going to have to be by First Nations, for First Nations. It's got to be owned by Indigenous leaders. And the good news is we've got a whole new crop of Indigenous health leaders that know how to get it done. Almost need to get out of the way.
All right, let's see what the audience thinks, and I now have a screen in front of me. Thank you very much. Yeah, the polarization has ended. It's 92% saying, no, we are not doing enough. But as you say, that could even be good news. It's a sign that keep the fire lit underneath them. Do we have time to get to the fourth question? Yes. Okay, good. We were hoping about this. I think in the government's mandate tracker, everybody's familiar with that, it calls the promise to get health accord with the provinces fully met or, completed. Fully met and completed. And that is because there are individual deals it made with the provinces all in over the course of the past year. So our question is, do you agree that this can be called fully met or complete, that the federal government has reached an accord? Peter, why don't you start?
Sure. Well, I think, go back to when we saw the federal government and provinces sign a 6% escalator with no strings attached. There's some serious challenges in the healthcare sector at that point in time. You had chronic underfunding, low salaries. You also need a federal government to have a stake in the game when it comes to provincial healthcare delivery. Fast forward, we are in a different state in the healthcare system. You had a federal government and provinces that knew that these were two priorities that needed to be addressed. So the answer is yes, they did achieve what they said they were going to do. There will always be questions if it was enough money. But what I think it does is it sets a template for how the federal government can provide funding to provinces based on priorities. It got them out of that 6% escalator, no strings realm that they were in, and we now have a new template to solve whatever future problems, maybe it's pharmacare, maybe it's something else, that the federal government and provinces see fit.
What do you think, Jennifer?
And no, I agree. This obviously was not the accord that the federal government hoped for initially. But I think considering the circumstance, they got as far as they could get. And I think, as was described, the important aspect now is that there is accountability where there was very little before. And I think that was an important hurdle to jump over, and I think it's set us up for a much healthier interaction in the future.
Bill, what do you think?
Well, I think it's a stretch to put a check mark opposite health accord.
Yeah.
It's not the health accord that was promised. What was promised was a multilateral accord delivered in the spirit of sunny ways, right? I think this is more an example of bond cop, bad cop, in terms of the Minister of Finance defending the till and the Minister of Health doing a good job of buying change this time as opposed to just buying peace with the provinces. So I think it's too early to tell. There's a series of bilateral agreements that have to be followed up with each of the provinces and territories. Only 2 have signed on in terms of common indicators, Newfoundland and Labrador and New Brunswick. So I think there's a lot left to do, but the 2 key areas that they're focusing in on, home care, right, community care, and Jenny's already mentioned it, mental health and addictions. If you ask Canadians what are they most worried about, those are 2 areas that they're most worried about. So Godspeed in terms of addressing those 2. But back to Peter's point, is there enough money? $11.5 billion over 10 years, spread over 13 jurisdictions. Somebody from Alberta said that covers 15 minutes of the running costs of the Alberta Health Services program.
Wow. I know you've all mentioned it before. Do you think health is going to be a big deal in the budget?
I think we saw a significant commitment, the 11 billion plus in previous budgets. So I don't think it will be a health budget because I think there was a significant amount in previous budgets, but to be seen.
We're now going to go to the results of Bill, did you want to say something? Yeah.
I'm going to disagree with Peter on that. This better be a health budget in 2 respects.
Yeah.
One, CIHR, as Jenny's already mentioned, they took a time out last year, nothing to CIHR last year. And unless we start to reinvest in particularly our researchers in the future,
Yeah, that's
we're going to be
point.
left high and dry. Point number 1. Point number 2, infrastructure. It continues to be dialed out in terms of federal investments in the very institutions that they help build.
You had some.
I would concur there. As I say, we're all waiting for, with bated breath, to see a significant level of support for health research, support the report. And I'm hopeful that there will be some influx of funding as well to support our work on Indigenous health, because that's what it's going to need.
Well, that was me slipping in another question there secretly, not so secretly. So thank you all for participating in this. The results of the last one are, again, we seem to be moving all more of as a group. No is the answer, with the idea that the government can say that the fully met obligation. So I think we are going to move it back now to the next stage. I thank you all for taking part in this. Well, thank you to the panelists here, and back to Catherine.
Thank you, Susan. I think it's a sign of the size of the healthcare debate that we can have a 20-minute conversation to start it off and still have another 40 minutes of a whole panoply of other health-related issues to talk about in the rest of this segment as well. So thank you to you and your panel. So we're moving on now to the policy segment, and I am delighted to have 4 distinguished guests who will be joining me on stage one by one for a one-on-one conversation, and then we're going to end up with a group discussion with our audience here and online. this is your opportunity to put your questions into Slido as they come to you during our discussion. But allow me first to introduce our first guest, who is Pamela Fralick, the CEO of Innovative Medicines Canada. Thank you for being here. I think we're okay with the music. Pamela, I'm going to start with a question with regards to the generic pharma industry, because it was news yesterday.
It was. Yeah.
So there was an announcement yesterday that, in fact, the generic drug industry has agreed to cut prices up to 40% in a 5-year agreement with the provinces. Mm-hmm. What is your reaction to that? What kind of impact does this have for Canadians?
It's a great subject to raise, given just how timely it is. I don't.
We're awake now.
That wasn't
We're
my
good.
comment. That wasn't my comment.
Good.
There's not a lot, certainly officially, that I can say. It just came out late yesterday, midday, I believe, and we're taking a look at the details and what has unfolded. But on the surface, from what I've seen, first of all, anything that we can do in terms of bringing prices down for this cost containment issue, the sustainability of the health system, is a good thing. And frankly, we know that generic prices in Canada were higher than most other countries, so there was a little bit of room for movement, I think. So that's a good thing.
And that most people are getting generic brand drugs. Is that correct? Am I correct in reading that statistic that that there was, in fact, a large number of people who were getting, through their plans, generic brands?
Yeah, that is the go-to position, whether it's employers or governments.
Yeah.
Once a product does become genericized, then that's a lower price, and let's include that. But the other thing I would cite from what I know about this process, two things actually. One is sustainability. So it's a 5-year agreement. That's good for Canadians. It's good for the industry, I'm assuming, just some predictability and sustainability. But the most important thing that I would cite is that, again, from what I can tell, not having had the opportunity really to explore yet, is that this agreement was created through dialogue. I believe both the Generic Association and PCPA, the Pan-Canadian Alliance, had a good conversation about what makes most sense. So they're supporting the governments and their budgets, as well as an industry that still needs to thrive in order to bring the product to Canadians. So it's that dialogue that I think was really important.
Can I just follow that up really briefly?
Yeah.
Are you mentioning the dialogue because that's been lacking previously? Has there not been that dialogue?
Well, I'd have to move you over into my area right now, which is the patented medicines,
Right.
Innovative Medicines Canada. Yeah. And I mean, we get it loud and clear that prices are a concern. Price of the health system in general, obviously, and we've been hearing the comments earlier, is a huge issue right now. So there's no question that we want to be part of that solution. And in fact, in my time with this industry, the last year, we've worked very, very hard to come up with creative ways that we can help governments deal with this very sustainability issue. But to be honest, from what I've seen, and it pains me as a Canadian, as someone from the health sector through all of my career, the meaningful dialogue of folks sitting down and absolutely respecting that governments have the accountability, the responsibility to make the best decisions for the populations, but do it with all of the context, all of the information. And we haven't had that opportunity from this particular industry to contribute to that dialogue. So we're pushing hard to make that happen, even as the government is considering quite significant regulatory changes right now. We want to make sure that whatever comes out of that process is the best possible.
Right.
Yeah.
So in terms of investments, the innovative pharmaceutical industry has an investment target of 10%.
Correct.
And the Patented Medicines Price Review Board has said that the industry is only hitting 4.9% in terms of investments. Mm-hmm. And I wondered if you can talk to us a little bit about why a target is necessary in the first place and why that target isn't being met.
Well, I'm not sure why it's necessary. I think it's a good thing. It's it confirms the industry's commitment to investing in the country in which it's working. It allows the government to understand that yes, there is that mutuality, I guess, in a relationship. Beyond that, I wasn't around when it was first discussed, but certainly it's a helpful thing for the whole system, I believe, and the industry is keen to do that. The point that you raised, though, and maybe this is a chance to speak to that, because I think the sound bites that have come out in the last number of months, this last year, have been I call them accurate but incorrect. So let me explain.
Okay,
When-
that's not fake news, right?
Absolutely no.
Okay.
What does that mean? In 1987, this agreement was made. Again, I wasn't around at that point, so why it might have been deemed necessary or good or appropriate, I'm not sure. But it was good for the country and for industry. Industry wants to invest in Canada. It's a fabulous place to be investing in. We have good infrastructure, good researchers, good clinicians, a great place for clinical trials. But the definition of R&D was quite narrow at that point. It is one specific program that government offers. It's a tax credit, SRED, S-R-E-D, Scientific Research and Experimental Development, I think it is. We use the acronym. And that was very much responsible for industry increasing their investments over years. You can follow it from 1987. It dropped off at a particular point. It is down to 4.9% most recently, the last year that the PMPRB, the Patent Medicine Price Review Board, gave data. So it's accurate in that respect, but the business model has changed. Industry invests in so many more ways than this one program through the government. So they are still investing almost 5% in this SRED program, but they're
investing in other ways as well.
They invest in J-Labs in Toronto, people have heard of that, Zymeworks out west, research chairs, they fund charities to do research. So Ernst Young released a report just in this fall. They were able to gather data, proprietary data, really unprecedented data gathering, to really understand what the economic footprint is and the investment of this industry. And they determined that if you count everything that we think is research, now we haven't had that discussion yet with government to decide if they agree with us, but it comes out at 9.97%. It's almost unfortunate because it's so close to that 10%, it sounds a little bit fixed. It wasn't. It was very accurate data. And in fact, that only accounts for 80% of our members who were in a position to provide that data at that point. And not every company is a member. So we know it's far beyond 10%. So that's the correction that I'd like to make to the soundbite that's out there.
I really appreciate those points, and I think that we'll probably have a lot of other questions from the audience with regards to this, because we're hearing a ton about the issue of prescription medication, the funding of it, pharmacare in general.
Absolutely.
So looking forward to more conversation with you. We're going to play a little game of musical chairs now, because we're going to bring our second guest onto the stage. Pamela, thank you. You're not going away. You're not going far. You're going to seat number 4. So I'm really pleased now to have the opportunity to welcome our second guest, Pauline Tardif, who's the CEO of the Alzheimer's Society of Canada, to this stage. Come on up, Pauline. We're delighted to have you here. Merci. Alors, merci d'avoir choisi d'être parmi nous aujourd'hui. En effet, there is, clearly we're all aware that Canada has a growing senior population, and I would be willing to bet that every one of us here in this audience either knows someone or is directly related to someone who is in fact dealing with a dementia-related issue or an Alzheimer's disease. And Pauline, I wonder if you can talk to us a little bit about what changes need to be made to ensure that the healthcare system can respond to what's being called an epidemic effectively.
Well, the other thing that is a guarantee is everybody here is aging. So that's a non-negotiable.
Except us, Pauline.
Non-negotiable, and the reality is as you age, your risk of living with some kind of a sort of dementia increases as well. The important thing is to be able to pay attention to that. It's not a surprise that the population of baby boomers in Canada is aging. We knew that 10 years ago. We knew where we would be today. And suddenly, we find ourselves a bit surprised at the cohort of seniors and those living with dementia in particular being a high percentage of our population. And that baffles me because, of course, we knew that was going to happen. But suddenly there's a sense of urgency to be able to react to that and to do that proactively, to be able to adapt the healthcare system, to be able to support people living with dementia and their caregivers, which we know is also a significant cost, both for personally for caregivers as well as on the healthcare system.
So that's a really interesting point with regards to the caregivers as well, because in fact they are so directly impacted by the disease itself when caring for a loved one, a parent, an older sibling, etc. I guess what we should also talk about, though, then is how you raise awareness of the disease. Because if, in fact, we've reached a stage where we all know we're aging, hopefully gracefully, but we all recognize that this is coming down the pipe, so to speak. So what do we do to raise awareness? What do we do to ensure that when people receive a diagnosis, that they and their loved ones have the support that they need to effectively deal with the illness?
That's a really important question for us at the Alzheimer's study and for the population at large, I would venture to say. The Alzheimer's study did a recent survey of Canadians, and in fact 46% of them, of the respondents, responded that they would feel shamed or embarrassed of living with Alzheimer's or related dementia.
Wow,
and that's very concerning,
Yeah.
of course, because why would they feel ashamed of having a health condition? Would we feel ashamed if we were living with diabetes or cancer or another chronic health condition? Probably not. And so we need to get to the heart of that fear, and of course you combat fear with education and awareness. So I would say that the other piece of that story is that with that fear, people are actually avoiding diagnosis. So we learn how to hide things, we learn how to dismiss things, and that's not good for dementia, because the reality is the earlier that you identify possible issues with your with your cognition, there's more that we can do there to be able to delay the onset or the symptoms of dementia, Alzheimer's or other dementias. And so it's very important that we get to the awareness piece to be able to also be able to eventually treat or at least address some of the symptoms related with dementia.
And I have to imagine a ton of it has to do with fear. I mean, if you can educate people about the fact that there are treatment or delaying options available, as you said, I think that goes a long way to helping people want to have the conversation, because then they know that there is a possibility in their hands to do something about it.
Yes, and
Yeah.
the stigma associated with it is the unknown. And so when we think about somebody living with dementia, unfortunately, we skip to end of life and to end stages of dementia. And we forget that the person has many, many years to live, often in great quality of life, and that we just need to support their dementia journey, if you will.
Thank you for being with us.
My
There's
pleasure.
more to this conversation.
Thank you.
You get to have a seat beside Pamela, and I'm now thrilled to bring up Mike Villeneuve, who is the Chief Executive Officer of the Canadian Nurses Association. And we are clearly nursing is an environment which is changing. Mike, we're delighted to have you here. Thank you
very
for being
much.
here.
Thanks, Catherine.
So, should we be actually looking, Mike, at deploying doctors and nurses differently in order to better ensure the health of Canadians? Are we doing it the right way?
Well, you've just heard an example of the way population health has changed, and the kind of competencies and care that those folks require is different. But if you looked at the way the healthcare system is structured, I would say you'd be hard-pressed to see that much has changed since about the 1980s. So when we look, for example, at the way nurses are deployed, I have a colleague who's fond of saying, you could drop Florence Nightingale into any hospital in the country and she'd know the routine, because it really hasn't changed very much.
Right.
In the meantime, we've educated the best educated nursing workforce in the history of this country. You would not know that if you saw the way nurses are deployed to work. So we spend about 15% of our public dollars on physicians, about 13% on the 400,000 nurses in the country. And I think we're having a look at the Canadian Nurses Association and how are we deploying those people to be most effective when population health has changed, long waits for primary care, long waits in emergency rooms, long waits for specialty care. Something isn't lining up.
So what needs to change?
Well, one of the solutions we talk about is how to deploy those nurses to provide some different kinds of care than they currently do. So let me give you a simple example. One is around, we've educated nurse practitioners, so we had, someone can tell me, I don't know if we had 100 in 2006 and they weren't regulated and so on. We now have more than 5,000 working across the country, prescribing, able to do a number of things for primary care that typically a GP would do. But we can also deploy the regular nursing workforce to do a great deal more of that. So I was in London recently and had a health problem that had been going on for some time with a cough. It was very interesting to go to a clinic led entirely by nurses.
Are you talking London, England?
London, England, in London, England. Nurse-led clinic within the NHS, in the public system. All nurses, 200 patients a day, see you within 5 minutes of arrival, guaranteed to be finished within 2 hours. So there are models out there. We know that where nurses are very, very effective. We know that the care is safe. It's as effective for the patients and as satisfying for the same or less cost.
So why aren't we doing that here?
Well, there's a tremendous inertia, I think, around the kinds of competencies within the physician group and the nurse group, and I mean registered nurses, practical nurses, terrible inertia in trying to let some of that go. And my view would be that we have to understand nobody owns a competency, right? Many people can learn it. So we've scaled up our physicians a great deal, scaled up RNs to some degree, but we have a very long way to go. And I tell young students often, we forget there was a time when nurses couldn't do blood pressures and give injections, and when that was going to happen, there was a huge uproar that was going to be the end of the healthcare system. So nurses, the idea that nurses want to be docs or mini docs is wrong. We want to expand nursing practice to provide more primary care and so on. The great example in Toronto, and I'm pleased to see Maureen McTeer here, who was the co-chair of the National Expert Commission, and we discovered this study during our work in 2011-2012, where the emergency room was very crowded at Toronto Western, and like they are across the country, big tertiary care hospital. And they noticed that they had a lot of old folks, typical also of emergency rooms, long waits in hallways on stretchers and so on. And they simply did a small study and asked the question, what if we sent the nurse out versus bringing the patient in? In that one-year study, 80% of those transfers would have been eliminated and a 20% savings in the cost. So one of the things we said at the time was, why don't we just replicate that model right across the country? Since emergency room wait times is such a huge thing, it simply has not spread, and it seems to be a really intractable problem. And it's not a doc versus nurse thing. We have it within nursing. Practical nurses, their scope has increased, their competency have increased. So we think there's a lot of room to deploy those 500,000 nurses and docs differently for that high cost.
There's clearly more to this discussion. Maybe we could do an entire show on this. But thank you for being here. I know we're going to have more questions on this as well later in the show. And again, we're doing our musical chairs. Thank you very much, Mike.
Thanks.
So 3 very interesting perspectives, and now I'm thrilled to ask Marilyn Gladu to the stage. Marilyn is the Member of Parliament for Sarnia-Lambton and the Shadow Minister of Health for the opposition, the Conservative Party of Canada. Delighted to have you here. Thank you very much.
See you.
Yeah, we're thrilled to have your perspective on this too, because your role really puts you in the thick of these types of decisions as well, the policy decisions, the path forward, where we go from here. 2 questions for you, but I'd like to start with the national opioid crisis, because we heard very little bit about it earlier during Susan's segment, and it's affecting not just the individuals who are in fact suffering from addiction, but entire communities. And it's also affecting not just the healthcare system, but first responders and others as well. How do you tackle this problem?
Well, I think it's important to make sure that you tackle it on several fronts. The first part is prevention. So preventing opioids from coming into the country, preventing overprescribing, because most addiction facilities will tell you that the addicts that they have started either with prescription drugs or with marijuana. So Starting on the prevention side, arming up the first responders to be protected, because there have been deaths and there are people that are frightened to intervene because a little speck of fentanyl can be deadly.
Right.
So prevention for sure, and then I think we have to get more treatment. There's inadequate treatment facilities across the country to get people off drugs, and that's really what the ultimate success is, preventing people from taking drugs in the first place and getting them off drugs. And so I know that the government has been focusing on safe injection sites, but I really think in terms of prevention and treatment, more is needed.
Yeah. You had an incredible success with the private members bill, Bill C-277, which just recently became law.
Correct.
And it's with regards, the focus of the bill was palliative care and ensuring that Canadians had access to palliative care in their communities. It's clearly both a professional and a personal passion for you, but it's also a really major issue as we talk about MAID, medical assistance in dying, and as we talk about we do have, as we discussed, have an aging population, and people want to have some element of control. Can you tell us about the bill and what you're hoping that Canadians will have access to?
Oh, sure. Today we have 1 in 6 are seniors in our country, and that'll be 1 in 4 in just a few short years. And so the bill is to get consistent access for palliative care for all Canadians. And 70% of Canadians today have nothing, no access to palliative care. And so, in their suffering situation and in light of the MAID legislation that came in, we need to do something. And the something that needs to be done will involve money. But the government and all parties supported the bill. And the government has pledged $9 billion so far. I think there was $3 billion in budget 2016 and $6 billion in budget 2017 for home and palliative care. Now, unfortunately, they've only spent $200 million of it. So I wrote a helpful letter to the Minister of Health, and I'm looking forward to working with her on where that $9 billion could go. But we certainly need more hospice infrastructure. We have less than 100 of them in Canada compared to 1,300 in the US. We are short of the service providers at all levels. We're missing at least 400 palliative care specialists. Many nurses and doctors receive no training in palliative care, and so training is another big piece of the puzzle. And then in rural and remote places, to try to figure out how to address bringing care there. There have been a number of really innovative solutions. In Nova Scotia, they started training their paramedics so that when they weren't responding to an emergency, they could administer, pain-controlled palliative care. And that's a model that is both good for the patients who are having difficulty finding the transportation to get their treatment, and good from a cost outcome for the healthcare system, because there's a fixed numbers of dollars there, and as people start to need more money, palliative care in hospital costs about $1,100 a day versus hospice $200 to $300, home care less than $200, and the paramedic model $90. So I think we have a chance to make our health dollars go further and get a better outcome for the patients.
What's been an interesting and consistent theme throughout this entire discussion with all 4 of the panelists here is this idea of how traditional models no longer work effectively. And so the importance of needing to innovate and think differently and outside of the box to, in fact, solve the major issues facing the healthcare industry in Canada today. So I've asked enough questions. We're going to go to you. We're going to go to our audience now. This is the people segment. And let's go to the first question that we have up, which is, are healthcare systems prepared to cope with and take advantage of the disruption and opportunities that AI, robotics, and big data are bringing? And Marilyn Gladu, I'm going to throw that question to you first.
Sure. I don't think they are prepared at this point in time. We still have different software programs being used in different provinces, and they can't share data. Makes it very difficult to see where we are at. Even if we think about antimicrobial resistance as an issue where we're interested to know what's going on there, we really don't have systems that will talk to one another. So there's a need for a big data solution, I think, and also AI and robotics is an ever-changing, quick-paced, changed kind of technology. And right now we have created a system in the provinces that doesn't allow for innovation. right? We don't want them to be trying things on patients and trying new things. And so I think there's an opportunity for us to shift that. I think the Canada Health Act actually prohibits them in some cases from doing the kind of innovation that they need. We need more research. I think that point was made earlier, and we need it in this area of AI and big data.
So the next question is one that everyone can have a chance to speak on. So Pamela, I'm going to start with you. And clearly this can come from your own industries. What should be the government's highest health priority?
So you want me to speak to that from my industry or
Yeah.
just from me and my general background? Well, for us, the highest priority is to get it right in terms of modernization of how they're dealing with patented drugs. As probably most people don't know, if you look at the cost of the system overall, which is a lot of what we're talking about today, drugs are in total around 16% of those costs. So we really do need to modernize the system and get going on infrastructure and hospitals and HR costs, HHR, Health Human Resources. Of the 16% of drugs, patented drugs are only approximately 6%. So it's a fairly small amount, and yet it's still a lot. So if there's going to be some changes to how they're priced and how they're dealt with, then that is a good thing, but it needs to be done with dialogue. You and I spoke about that a moment ago. They at the moment do have proposals out to change this 30-year-old system of regulating patented medicines, but they have, in our view at the industry, not had the benefit of a lot of extra information and context that could make the decisions ultimately be much, much better and better informed. So we, again, as I've said, understand that prices need to come down. The government wants to reduce prices. We'd like to support the government in reaching their goal, make it a political and a Canadian win, but do so that it doesn't have such an impact on this industry. And we haven't talked a lot about that, and this is probably supposed to be a short, succinct answer to your question. However, certainly if the impact of the regulations go forward as proposed, the industry will have to retreat, and they currently support 30,000 very well-paid jobs. There will be loss of jobs. We invest, as I mentioned earlier, 10% of revenue. That's about $1.2 billion every year. That will decrease. We support, at the moment, at any given time, 4,500 clinical trials. They will not take place. In the end, patients, Canadians, will not get access to drugs as they should. So those are some of the implications, and that, for us, is the highest priority issue.
Pauline, if you had one issue, what would you want the government to put at the top of their priority list?
Well, over 500,000 Canadians are living with dementia today, and it is the most feared health condition from Canadians. So obviously, I think that's a very important file to look at. But I'd say that the highest priority should be, I'll join Madame Moineau in saying investments in healthcare research. So it is very challenging for healthcare charities such as ours at the Alzheimer Society to be able to address some of the issues, such as what are the best approaches in healthcare, in long-term care, in home care. These elements of the healthcare are well established, but they don't have the data to be able to have the flexibility to support people living with dementia in the way that they should be supported to really fulfill the full quality of life that they're able to have. The Canadian Institutes on Health Research has requested dollars in the budget. Health charities support them in that. We are partners in supporting research, and it is through research that we will better understand dementia, other chronic healthcare conditions as well. And I think that the government is poised to do that.
Mike, top priority?
You can hear the complexity already of what we expect poor governments to have to do. It's such a handful. I would say governments across the country need to do everything they can as quickly as they can to continue to shift the focus away from rescue, treatment, and acute care when the population needs, as you've heard examples, chronic illness, end-of-life care, palliative care. Those are the demands, primary care. I always say, if I walk out here and get hit by a bus, I'll be damn glad that there's a really great acute care system and a trauma unit. It's very good for my individual health. But hospitals, the hospital system, and rescue doesn't do much for population health, and that's where our problem is. So I would keep pushing the focus to be population health, what's the actual needs, and how can we meet those more effectively.
All right, well, all of the answers have been good, but I would look to where the largest gap is. And I think mental health is a huge area of underfunding in the country. I think we've seen a suicide crisis across the nation. We see in every riding that there are people who are a danger to themselves and a danger to the public, and there's really nowhere for them to go other than prison, which is not the answer. And so we really need to address the funding of mental health and come with solutions that will be good for Canadians.
Mike, how can governments and industry focus more on proactive measures to improve health versus being reactive?
I was just thinking about that issue because we often say, using the example of dental care, that fluoride treatments aren't very sexy, but they work over a number of years. And a helicopter and a trauma unit's a very sexy, fun thing to do really very quickly. So the issues around weight, smoking, drinking, and addictions and so on are often not the sort of colorful, fun things to talk about. So I think we need to continue to try to do what we can to spin those models in different ways so that people are interested in them, even down to things like certain kinds of technologies. And we know, for example, from some experiments in Japan, that people actually respond better to a robotic toy teaching you something sometimes because it's interesting. So I don't have an answer to the question. It's too complex for me, except to try to find the tricks that keep people interested, whether it's through apps and so on. Because it's look at the problems we have. If it was easy, we would have fixed it. We already have the knowledge. It's just very tough to get people to live a certain way.
Yeah.
No, it's not a very good answer, but maybe others have.
Yeah. I'd be interested to hear what you have to say about that, because you're sitting in an environment where you're actually trying to create the policy change.
Truly, and one of the things that would make people more healthy is if we had less obesity. So honestly, you are what you eat. So looking at getting people to eat healthier and to exercise, that goes a long way to preventing a lot of the chronic disease that we're seeing with people, huge increases in diabetes and a number of other issues that are, hard on the body, basically. So that's a key thing that we need to get working on. I think the other thing I would like to see us be more proactive on is where the spend goes. We see that there are really not enough frontline people. We see the wait times going up, and that's a case of funding and where it goes. Does it go to administration or does it go to people and equipment to treat patients?
Right. So we're going to do, Pamela, did you want to?
Well, I was just going to throw out a comment. I'm not sure if the question in mentioning industry was specific to the industry I'm working with right now, but in case it was, I'll become a broken record on this message, but working together, I think we'll be served so much better as Canadians. The Innovative Medicines Canada world is innovative, it is creative, it doesn't know everything about the political world, the bureaucratic world, the government world, but it is pushing the boundaries on a daily basis and has some really astute observations and creative ideas to bring forward. There's always going to be tension between government and industry, of any kind of industry, recognize that. But if we can have a meaningful dialogue, get to that table where we can have the exchanges and shift the needle a little bit away from the reactivity, the proactivity, let's work on it together. So again, a broken record message.
But the dialogue element is
get
key.
talking, yeah. It's a starting point, it's not the end point.
We're reaching the end of our time, so we're going to go to one final question. And Pauline, I'm going to throw this to you because you brought it up. Why is there not more talk about health research funding?
I think there is actually a lot of talk about health research funding. What we need is more action and more money. For instance, I'll just take dementia again because the space I know. If we wanted to compare ourselves globally to dementia research and the importance of that and levels, let's say in the UK or Australia or just global levels, at a very minimum to get to the next comparator, which is the UK, we would need to close to double the amount of funding for health research into dementia in Canada. And that's not an unsubstantial amount. And so what we need are the dollars associated to it, but there's a lot of talk about it, I would say.
So there's also a lot that we can talk about for at least another hour here. Undoubtedly, we'll be doing another health checkup in the coming months because these issues continue to evolve and to change, both at the policy level and for Canadians as well. And really appreciate that you joined us here today. Thank you very much. Thank you also to Susan's panel and to Susan as well for that very interesting way to start off the moment. Et merci également, mesdames et messieurs, à vous pour avoir choisi de nous joindre ici ce matin au CNA en direct. Je voudrais encore une fois remercier nos sponsors. I'll thank again our sponsors for their help in ensuring that today was a success. The Canadian Nurses Association, the Alzheimer Society of Canada, Innovative Medicines Canada, the Canadian Ophthalmology Association, the NAC, and Skyfly Productions. We'll hope that you'll also join us for other Before the Bell events. We have a February 23rd budget outlook, which I think will include some discussion about the healthcare element as well, clearly. And we also have a Women in Business event, which is taking place on March 8th, which of course everyone in the room knows is International Women's Day. So we hope that you'll start off your International Women's Day with us for that as well. You can visit our website, which is www.sixthestate.ca for more information on all of our events. You can also follow us on Facebook and Twitter. Thank you once again to our panelists. Thank you, ladies and gentlemen. Je vous souhaite une très bonne journée. Merci de votre présence encore une fois. Thank you very much. Great to be here.